So fire when ready.
Okay, so we are Team 8. My name is Lakin. I'm a student physical therapist.
I'm Daphne. I'm a master's in nursing program.
I'm Dave. I am a student dentist at Rosedale.
And I'm Morgan. I'm a master's social work student.
So we're sharing with you our thoughts about this case, and we hope you enjoy. So meet Dorothy. This is our patient. She is a 77-year-old African-American female. She lives here in St. Louis with her son and granddaughter. Her granddaughter brought her to the emergency department because she noticed she was having some slurred speech, wasn't able to get out of her chair. Since Dorothy has a history of stroke in her past, her granddaughter was pretty concerned, so brought her in. With the workup, they found that there was no CBA, but we have other concerns as her healthcare team.
So on investigating what was going on in Dorothy's life, we came up with several things that we need to address. She was dehydrated, and we did some labs on her and noticed that and looking at her BMI, which is 19, that she's malnourished. She has anemia. We suspect it possibly could be due to the malnourishment. She's got some polypharmacy going on and some adverse drug reactions going on between some of that polypharmacy. There's a poor management of diabetes. Her A1C is 9%. She has a purulent wound on her left lower limb and signs of impaired vascular. We don't have any pedal pulses that we can feel in her feet. And she talks about the fact that she has vascular problems. So she's definitely got some big vascular problems in her peripheral system. She's got some uncontrolled pain that's not being addressed in the hospital that we need to make sure we're taking care of that. She has mobility limitations that makes her a fall risk. Ooh, oh, that happened, sorry. Go ahead, I pushed the wrong button. Sorry. One back, there we go. She's got some visual problems that we would like to take care of and address. She needs her assistance just to perform everyday living issues that she needs help with, which is her son's at home and moved in to take care of for her. She's got some dysphagia. We've noticed some cognitive defects going on, and she needs to be assessed for that. She has depression, anxiety, and since she had her stroke 3 months ago, she's been socially isolated. She has urge incontinence. She has poor oral hygiene, and part of that oral hygiene is she's missing teeth. She has dental caries and thrush going on in her mouth at that time. And because of a lot of things going on, the cognition, the purulent wound, the vascular problems, she's having some problems. She's extremely big fall risk. And her medical history that we have is that she has type 2 diabetes, the urge incontinence, the stroke that she had 3 months ago, depression and anxiety, chronic kidney disease, hypertension, and osteoporosis.
I'll mess it up, I promise you. I promise you. Okay, so some concerns about Dorothy is that she is presenting with signs of physical abuse and neglect. And as medical professionals, we do are mandated reporters and have an obligation to report that. So move to the next slide. So some of the signs we did see were circular bruises around her wrist, bruises on her legs. So she does live with her son, and her son was at the hospital with her, and just the interactions between them, the son was definitely concerned about the money being spent in the hospital, and she was very worried about pleasing her son, and just the interaction between them was a bit fearful at times. She did come to the hospital smelling of urine and appeared very unkept, so poor hygiene. The malnourishment and the dehydration were also issues, and then the open wounds that were not addressed. So due to all these signs, these are things that we would hotline for. So one of the things I wanted to talk about too was not only are they going to come in and investigate, but they will also offer resources, help with the caregiver stress, because just some background about the son is that he did just lose his job. He's now working part-time. He's taking care of his mom. He also has another daughter, the granddaughter that brought her in. So there's just a lot of caregiver stress. So I really think hotlining would not even just help with the investigation, addressing the abuse and neglect, self-neglect, but also providing resources, particularly caregiver stress and case management. So we wanted to also talk about ethics in this case, particularly self-determination or patient autonomy, because the big issue is going to be with Dorothy's discharge plan because of the abuse, and just being sure that we're being respectful of her right to make her own decisions. So I did put in here about the fact that she is a comment person at this time, and she has the right to make unhealthy decisions. So until two doctors deem her incompetent, she has that right until it can be given to a power of attorney or a guardian, which it did not mention that she had a power of attorney in this case. We also put in here about cultural considerations. Because she is African American living in North County, we did think that that was something that needed to be addressed, just because of mistrust of medical staff due to previous studies that have been done. The Tuskegee that was done previously, there is some mistrust in that culture. Also, with her age and the Great Depression and views of money, it's very hard for geriatrics to let go of that, let go of their stuff. And then just a strong kinship.
So keeping all those concerns, considerations in mind, we come up with our goals for Dorothy. First and foremost, keeping patient number one. Her goal is to go home. She wants to go home and to be as independent as she can within her home. The family kind of seconds that and says, I want her to come home too, but we want her to come home ASAP because they're really concerned about finances and keeping medical spending down. Kind of moving into our thoughts as we read the case, we want to create a positioning schedule with her, skin checks, that way we can totally minimize risk of pressure ulcers or any other kind of bed rest issues. We don't want her leaving with more issues than she came in with. Part of what Daphne talked about was polypharmacy. We want to look at her medication list and see what can we modify, what can we change, what can we look at to really minimize adverse reactions. We also want to focus on her malnourishment and dehydration so that she's healthy, keeping in consideration her diabetes, dysphagia, and other medical conditions she has going on. We want her to be independent. We're kind of seconding that as well with Dorothy. Want her to be able to be mobile within her home, being able to do independent daily living tasks. We want to reduce her risk of falls. We want to look at her wound. We also want to maybe initiate, maybe not fully, this would probably bump into outpatient as well, but maybe get some bladder retraining. As physical therapy, we can look at some pelvic floor exercises, maybe helping her with that incontinence. We want her to really utilize resources, not only to be engaged in social activities, and she's experiencing isolation at this time, but really using resources to get her proper medical care as well. We want to determine the cause of her cognitive impairments. That could be due to the polypharmacy, it could be due to her dehydration and electrolyte imbalance issues. Also, could be a new onset of dementia, so we kind of want to look at that and see what we can do for her. Other goal is to really think about where we want to refer to after she's done with us at the hospital. Who is she appropriate to see, and keeping in mind the finances and transportation issues that come along with that.
So as you can imagine, after we've briefed you on Dorothy's many health and psychological conditions that she has, she's going to have quite a team of healthcare professionals that are going to be working with her and her family to improve her health status. And you can see many here that are going to be working very directly with her, and even some outpatient sources like podiatry, ophthalmology, dentistry, that we'll try to get her in contact with so that she can improve her oral health. However, again, it's not just this team that's working independently of each other. They have to work, again, as a team. They have to coordinate their efforts to really begin to focus. And so using a key driver diagram, go ahead and go to the next one, based on what we have initially seen in Dorothy, we have some things that we're concerned about, and we'd like to get them addressed as quickly as possible, utilizing the team that would have the expertise in these fields. As you can see, with her visit to the hospital, the medical doctor and the registered nurse are going to have a great deal of interaction with her. She's going to be, she and her granddaughter and her son will be interacting with that nurse and with that doctor, coordinating and discussing these health concerns that she's experiencing. And then along the way, including all the rest of these specialists that can work with her in improving her overall and psychological health. Again, the question is how do we get all of the healthcare professionals to take care of Dorothy? She's one person, they are many, and they have many responsibilities on their table, as we all do in our professions. It's really hard to get everyone together on the same page to have a unified healthcare plan for the patient. So our idea was, while she is in in-house care, we'd be able to do bedside rounding with her and her family, having her family members present, having a team of healthcare professionals visiting her, discussing things with her and her son, and educating them, speaking with them about how they can improve on her health conditions, and how they can improve, especially the son, how he can improve as a caretaker of his mother. I'm sure he has a great deal of stress on him, being the only source of income in the family, and having to take care of her and take care of his daughter. He's got a lot on his plate, and he needs help. And so part of our team is not just to address Dorothy, his mother, but also to address him and his concerns, because overall, if we can help him, she's going to be better off as well. So we believe that bedside rounding is going to do great. Also, being able to assign follow-up care after she's out of the hospital setting, giving that follow-up and continuity of care that she can receive, and also he can receive as well. So he has lots of resources to help his mother. Those things that we believe will help unify our healthcare team to improve her health.
So some of my interventions as the social worker would be to discuss discharge planning with Dorothy and which way she wanted to go. At this time, we would be recommending a skilled nursing facility. So I would be talking to her about that, especially because she does have, religion is a part of her culture. She was very active in her church before her stroke. So something I could talk to her about is a religious-based organization that would help meet her cultural needs as well. And if Dorothy declined the facility discharge, I would work with her to refer her and her caretaker to different resources in the community. I put a couple of examples here, especially Colorado transportation would be really helpful for her, especially with all the outpatient appointments. Meals on Wheels to kind of take the stress off of cooking, off of the son, to kind of help with that caregiver stress. Catholic charities, there's also Lutheran Senior Services that could help, just depending on where her faith or spirituality lies. And then area of aging to discuss Medicaid and chore workers. Another thing I would talk to her about in the hospital is advanced directives. It's really imperative that she have some kind of plan for the future. And then also information about power of attorney. I would discuss this, but I would not have her go through the paperwork just because of the hotline that would be open at the time, but it's always good to have the information.
All right, so for the doctor, he's got a lot, or she's got a lot to do. They'd be doing the head-to-toe assessment of Dorothy, doing the diagnosis with that head-to-toe, reviewing her medical history, managing and reviewing her scripts, her prescriptions, ordering new scripts, evaluations, labs, monitoring the labs, and monitoring the evaluations. What we mean by evaluations, like having nutritionists come in and see what kind of diet we're recommending for her, and OT and PT, and seeing what's going on with her and what their evaluations are saying about her condition. Referrals, those referrals that we talked about to nephrologist and neurologist, an endocrinologist, and they would be, of course, doing some patient education. For neurologists, we would assume that they would meet the neurologist in the ER because she brought her in for a stroke, thinking she's having another stroke. But also, you know, like I said, we're not quite sure what's causing that mental cognition and if there's some dementia going on. One of the she's lost her sense of smell, and that also concerns us neurologically, as well as neuropathy, because when she came in, no one mentioned the fact that she had a pain of an open wound on her leg. Nobody said anything. That was not the reason they brought her in. So, and she has no pedal pulse, and she's having problems walking, so just a good evaluation to see if she's got any neuropathy coming in. As a nurse, there would be a lot to do. So I'd also be doing assessments, a different type of assessments, every 4 to 2 hours, depending on what the doctor ordered. We'd have a wound care nurse come in and do an assessment on what needed to be done with that as well, as methaletics or how we're going to do a 2x4. And so I'd be doing the following up care with that wound care what's ever been prescribed in the system. You know, I'd be doing hanging the meds, holding the meds, calling the doctor. For example, she went into the hospital and she's on 3 blood pressure medications, one which happens to be a diuretic, and her blood pressure is very well controlled and she's dehydrated. So I would call the doctor and hold that med and say, hey, she's on a diuretic and she's dehydrated. Would you like me to hold this drug or prescribe something else, or, you know, have another look at that, as well as the fact that she's on a benzo and she's having these cognitive problems and a tricyclet and just there's a couple drugs in there we want. And I'd be calling over the fact that there's her blood's not being tested. She's malnourished and we don't know what her blood level is. We know that her A1C is out and we're giving her insulin, well not insulin, but metformin and glycoside, but we don't even know what her levels are at. So these are things I'd be calling a lot of things to the doctor about. With PT, I'd be helping her with ambulation, getting to the bathroom. With her dehydration and malnutrition, there might be O&I, intake and output monitoring done, so I'd be keeping that monitoring. I'd be any open lab orders that the doctor wants done, because she's not very mobile and in the hospital for a while. There's possible that they may give her a heparin shot, so I'm going to be having those labs open in order and keeping on track of her PT and making sure that if there's any abnormal labs, I'm contacting the doctor. Monitoring vitals, making sure she's getting oral hygiene and teaching her about that. Bedside handoff with nurses, making sure that I always use SBAR communication when I'm talking with the doctor so we can get things done very effectively and very quickly. And coordinating care, and that means with when we have other people coming in, she's got a lot of team members coming in and making sure that one's not overlapping the other and that we have a good schedule for her and that we're not also tiring her out. Turn schedule, making sure she's getting turned and we're checking her skin. Toileting, because she does have the incontinence and we want it, that will start with that bladder retraining and getting her to the bathroom every hour or every 2 hours to just see if she could go. Fall precautions, making sure she's on fall precautions, her bed's low, her rails are up when she's in bed, she can always reach our call light, contacting team members such as the social worker, when we have the signs of abuse and the doctor, therapeutic communication for when she talks about being depressed, education on so much. It's 20 minutes, we don't have time for all the education we go through. And of course, discharge planning, especially if she's going to go home. We're going to have a lot of education and planning we're going to need if she decides that she doesn't want to go to the skilled facility.
With rehab interventions, overarching goal with all of us, I think, would be increasing her independence while keeping her safe. That go through a lot of hands-on care, but a lot of patient education, making sure she's aware of everything that's in her home, rugs, pets, any obstacles, shuffling her feet, that we can make sure that she's safe when she does choose to go home. PT specifically, we'd be working on her mobility, able to get in and out of the chair, in and out of the car if need be, gait training, strengthening balance to help with all the mobility issues. We can start that pelvic floor strengthening program. That would probably be thrown out to outpatient though as well. Working with nursing on a positioning program, making sure she's getting pressure relief, and educating her about pressure relief, how it's important not to stay in one stuck position all the time. And also we can work on wound care as well, whether that's us, the primary, or we're working with someone else. We can do that. OT, focusing more on those tasks of toileting, bathing, dressing, making sure that she knows how to adapt. I guess her techniques, giving her adaptive equipment that she can use to better do those tasks if she does go home. And then making recommendations that are realistic. Her family's very concerned about money, so making sure that we're giving her appropriate recommendations. Like a chairlift may not be most realistic in this case, but maybe shower benches. So working with Dorothy and her family on that. Both OT and speech can work on cognitive issues. So giving her some of those brain training tasks. Speech would also focus on swallowing. She doesn't have to say that. She can easily work with the nutritionist to figure out the perfect meal plan for her, especially with the malnutrition. Nutritionists might be like, yeah, let's get her a steak. She needs it. She needs the protein, but speech is like, no, she'll choke to death. So they need the perfect balance to come up with a great plan. So leading into that, even more interventions for Dorothy, bringing in that nutritionist because of the malnutrition, coming up with a good meal plan for her, and a lot of patient education about counting calories, monitoring her glucose, teaching both the patient and her family why these are important. Help with the pharmacist. There'd be a lot of collaboration between the pharmacist and the doctor, streamlining that medication list so we don't get any of those bad drug interactions. Along with this, something that Daphne brought up, Missouri is the only, 2 minutes, thank you, only state that does not have a prescribed medication like monitoring program. So maybe pharmacists, maybe not specific to Dorothy, but for all patients, can contact our legislators and say, hey, like, let's get on this. Bringing in psych and clergy for counseling purposes as well.
Many of the other outpatient referrals that we're going to give, ultimately we kind of have a question, how is she going to be able to afford it? How will she be able to get there? So lining her up through the social worker, giving her those resources of the community, public transportation, other services that will help her to get there and to pay for these, because that is a big concern for her and her family. Many of the other outpatient services are directly related to some of her health conditions, and so keeping them in the loop and addressing those health concerns. My expertise as a dentist, go ahead and go to the next one. As a dentist, we're able to see some of the first signs of disease, and a lot of people don't realize that. We can see so much disease through the mouth. And unfortunately, Dorothy's part of a generation that has a different philosophy about dentistry. If it hurts, you pull it. You don't go into the dentist until it hurts. And so part of my job is to be able to address some of those pathologies that she might be experiencing. She may actually need a specialist, a dental specialist, to help her improve some of her functionality of her teeth. And of course, staying in contact with the physicians. If she needs major surgery, I need to know that she's diabetically under control. Staying up to date with her pharmaceuticals. These are all things that I need to take care of as a dentist. And of course, the oral hygiene instruction. Being a geriatric patient, maybe not having as much mobility in her hand to do oral care. Those are right up my alley to help her address that.
So you're kind of over your 20 minutes.
Yep.
How many more slides do you have?
This is the last one.
Oh, okay. Go for it.
So just for Michael talking about more caregiver support groups, resources given to the family such as CPR, and then definitely a case manager to be able to juggle all of things going on with her.
Questions? Judges, questions? Comments?
I have a couple of questions like this. I have 2 questions. So you recommended a sniff for her. Would that be a temporary or a permanent recommendation?
That would just be temporary for a post-acute unit to kind of deal with the wound care, just kind of depending on where that's at, and also to work more on the therapy.
Our idea was the fact that she's got a lot going on, and that we could get her hooked up with like Medicaid on top of her Medicare services. We could put her there temporarily to build her strength up. She wants to be more independent, and we want to be able to make her more independent. And if we can streamline all those services there and get her daily therapy, that's going to make her go home
I
more.
was thinking she owns a house, so that would work probably.
Well, Medicare would probably pay for a little while.
Medicare would pay
Yeah.
for the SNF,
Yeah.
but Medicaid would not be
Yeah.
a doable thing because she has a house.
Yeah, she may not be eligible for Medicaid at this point.
Right.
I have one more question, following up from that. So you mentioned, obviously I'm a physical therapist, so you talked about mobility, obviously, and the things that you would do mobility. You talked about bladder control, which was, some things out of the box that we think about, and talked about wound care, which we can do as well. One thing that I was curious about was the positioning schedule. Because for me, I'm curious as to what warranted you to that. I think as a physical therapist that we try to encourage mobility and movement as opposed to turning schedule. And I think when we put somebody on a turning schedule, those are more people who are bedridden. So I'm curious as to the thoughts as to, you talked about both. So how they coincide.
Within the hospital, I can speak to the nursing part and the turning schedule. And the fact that in the case study, she's not mobile. She can barely walk to the hospital, to the bathroom.
Yeah.
She can't walk without assistance at all. And when she gets up, she doesn't want to walk. She's in pain, she explained, and when I talked about the uncontrolled pain, it's only when she gets up and stands on her legs. She says she has a 5 out of a scale of 0 to 10, and she's not wanting to walk, so she's not being mobile at the time. So for the hospital, she is going to be in the bed. She's going to be hooked up to an IV, obviously with the malnutrition and with the, especially the dehydration. So it's going to be dangerous for her to move anyway. She's a fall precautions. For her to get out of bed, she's got to let us know, and we're going to, let her know, hey, you've got to get out. Call us, we'll come get you, we'll take you to the bathroom, we'll help you out, whatever. But she's not walking, so she needs to be turning if she's not turning herself.
Correct, and I guess my question is in looking at physical, and again, it's just kind of my philosophy of things, in turning her, I guess for me, I look at it as she is walking with therapy, she does use Menisys, she refuses to use a wheel walker, she does have pain, but the encouragement for me would be self-movement, because she's able to get to the edge of bed by herself, or sitting versus laying down schedule, and maybe it's worded different for me to understand true turning schedule would be more of something that would be somebody who can't turn themselves or somebody who is unable. And I understand 5 out of 10 pain, but 5 out of 10 pain as a therapist doesn't inhibit me from getting them up and making them walk.
So I know as a nurse that when we address that tells us, hey, let's look at what the doctor's ordered on pain, because a lot of times they'll put in there like pain 5 to da-da-da, or 2 to 3, give them 5 milligrams of oxycodone. But on top of it, for us in nursing sometimes is making sure that they've moved, because sometimes you go in there and you see in the last 3 times you've been in there, and you either for that patient bed or another, that they haven't moved, they've stayed in the same spot. So even turning is saying, hey, we need, can you roll over your side? You've been on your back a little bit, and you can even do things like, hey, I want to check your backside, because you do need to do those skin checks, and looking back there, and the fact that she's got a BMI of 19, so she's got bones on bones if she's laying there too long. And we didn't know, we didn't have the MD, but if she'd be on sequentials even, because she's got that wound on the leg. So we actually didn't address that because we didn't know the answer to it without a doctor.
It's an incomplete.
But yeah, it was an incomplete, and it wasn't in the case study. But for me, as a nurse, I want to make sure that she is moving. So turning on top of it is looking at, have you moved?
And I'm not saying you shouldn't at all. I guess I would rather see it be either a walking program or up and chair program as opposed to a positioning program.
Well, and she's probably changing quickly. If she came in really dehydrated, she, by a few days, she probably would be look a lot different, Yeah.
So that was I was just curious your reasoning, and thank you.
Okay, no problem.
So I had a question for you. So, I think it was really good that you caught the potential abuse here, both neglect, either self-neglect or family neglect, plus potential abuse with the bruising. How would that impact your discharge planning?
We had a lot of, I would say team tension maybe, I don't, obviously resolved, very healthy team tension. But I think having that safety concern, like I don't want her to go home just to go back to another bad situation. So I think that's why we were really pushing the sniff. a skilled nursing facility, but kind of like we're
And
going to
it's
address
just a
is
self-determination. I mean, if they're still saying
self-determination.
she's confident, can make this decision, I mean, we can hotline and then I would feel like it's kind of the state, I mean, can't make her stay.
Her slum
Can't
score
make
is
her-
not that bad, you know, 23
I'm
out of 30.
sorry.
Her slum score, her mental status,
Mhm.
so
It's not
she
like
would
she's
be
incompetent.
she would probably be competent, as long as she can understand the consequences of her actions.
Well, I know, we didn't give too much detail, but we conceived that, you know, she owns the house, the son and granddaughter are living there, she can't really sell the house, where are they gonna go? It would be a very
I didn't
sticky
know how
wicket to try to resolve that, so
how
I
that
think.
worked with the Medicaid, because isn't it with spouses, that the spouse can stay in the house and the house
But
is
there's no
accounted part of
spouse.
the. But with the son, I wasn't
Well, it
sure
also
how
depends on
different
the
that
value of
was.
the house and
Yeah.
all those things too.
Yeah.
I know also in the hospital, or at least from my experience, when there's been a suspected abuse and someone's been hotline, but, you know, there's an investigation, there's no proven, that we kind of put in a note, when this person comes in, keep an eye on it to
Right.
make sure. And so there's kind of like, you gotta leave the door open, you can't shut the door, and if they start yelling or say anything, then we kick them out. But there's there's literally a red flag in Epic that says, red flag, look at this, hey, this person has a special need with a possible abuse, so, and they'll tell you who, so you keep an eye out for that.
But there's
person.
enough to hotline her, I mean, I think that was right, and then someone will follow up, you may not get to from the hospital, but
Right.
someone will follow
We
up.
definitely talked about when to hotline too, and we definitely felt like this was something to do in the hospital, especially if she didn't, you know, decide not to go, but because there is sometimes some issues with, you know, hospital discharge or skilled nursing facilities, sometimes there's miscommunications.
Yeah, it's also good to talk to the family members about, oh, how did this happen? You know, and we noticed, you know, get each family member's, you know, report too.
One thing I was telling them is something that actually I learned last semester, 2 semesters ago in class, is when you do suspect abuse, and what she has, it says in the case study, he's talking over her, he's not letting her answer, you know, and he's taking over her care. And when you have a situation like that, you can get those answers by saying, you know what, I got to take her in for an x-ray, but we can't have you in the x-ray room, you know, and then you can separate them, wheel them in there, and even if you don't actually get an x-ray, you can have that time to get away. But different techniques on how to separate, so you can ask those questions, because of course when that abuser's there, you're certainly not going to ask those questions in front of someone that you
Right.
suspect is doing that. So there's definitely ways we need to also separate the fact that when he's there, because he was in the hospital talking over her and not letting her answer.
Great. Well, we have to end this.
Yeah, we have to go,
We're
go
over
quick,
time.
you got a quick.
Okay, so with the group rounding, would the family members be present for that, or would that be something that you would just recommend doing with the patient?
I think I would talk to the patient about what she wanted to do, really, just because, I mean, if she seems to have a really good relationship with her granddaughter, it's more the fact with the son, so, you know, I mean, I personally, as a social worker, would leave it up to the patient. It's kind of my go-to.
And I think, you know, especially with the nurse, we spend so much time with the patient that over conversations, we could read that. Because I would let her know, hey, you know, I'd start that education in there.
Yeah, we have to move on.
We're in the other
Sorry,
team's time
Pam.
now.
We're on